This is Derek Len. We're setting up now for radiofrequency ablation of lung using Fluoro CT. What you're looking at here is just getting ready. We've got the patient prone. This is a 3-lesion radiofrequency ablation. This is just positioning the point of entry. Put the 25 gauge needle across the point at which the laser cuts the skin, allows us to work out where to go in the XY plane. We then have to work out the Z-axis displacement in order to work out the angulation, so the angle in that we're going to come from below. We are placing the radiofrequency ablation probe now. This is under direct Fluoro CT vision. What I'm doing is watching the tip of the probe, moving the probe left and right and the probe hub up and down in order to steer the tip of the probe towards the lesion. In this particular case, the lesion itself is immediately behind the lungs. We've got the patient ventilated and we're using the ventilator to move the lesion up and down. So I'm just tracking that real time with Fluoro CT, watching as we advance that probe, just turning the bevel uppermost there, and once we're onto the surface of the lesion, which is where we are now, you see me pushing the handle down. That's advancing the tines into the lesion so that we can capture the lesion and commence the radiofrequency ablation. We rock the table backwards and forwards during this process using the remote control handle there. And this is just what you see as the tines are deployed into the mass in the lung. So this is the radiofrequency ablation needle coming in under the ribs and the tines deployed there to capture the mass. The next shot we'll see is the appearance after a small amount of cooking. You can see now we've got the energy probe, the radiofrequency probe cable on the back end of the probe there, and we're in the process of applying the radiofrequency current so that we can actually cook the lesion. The generator itself, we can see here, this is the Rita Therapeutics generator. In the circular component of the display is the temperature of the tines. It's a thermocouple arrangement. Target temperature has been reached at this point for this particular lesion. The power delivered now is quite low at 6 watts as we're finishing up cooking this particular lesion. 3 lesions for this case today. We're now in the process of working out how to get to the other 2 lesions. There's 1 lesion which is across an oblique the other side of a fissure, and the 3rd lesion which is further down in the lower lobe. So just looking at the lesion adjacent to the fissure, decided that we'll go for the lesion in the lower lobe first. So I think the lesion in the fissure is very likely to trigger a pneumothorax when we go to treat that lesion. So this is just Fluoro CT getting a handle on the amount of respiratory motion that we're going to get. I'm just pulling down now to reveal the smaller lesion in the lower lobe. It's visible as a little dense dot there adjacent to the leash of pulmonary vessels. We set the zoom characteristics on the Fluoro CT system. So the radiographers has set that, and then when we line up, we'll get a magnified view. As we discussed before, for Fluoro CT, we achieve spatial resolution through zoom, so you always want to zoom up the image so that you've got the region of interest and nothing else on the display. So we're just zooming that up there, and then as you can see, with the recalculated zoom, so it's devoting the full 512 matrix now to this smaller field of view, we've got a much sharper, clearer look at the target lesion. What you can see is adjacent to a couple of pulmonary arteries which we need to be at some pains to avoid. What we're going to do now is line up, again I've got to select a trajectory both in the XY plane. This has got the needle, you can see a little white dot there on the skin surface, that's the 25 gauge needle on the skin. So I'm working out a trajectory that will take the treatment needle away from those pulmonary arteries, so to come in oblique away from those. The next thing I've got to do is work out a point to commence towards the patient's feet that will allow me to angle up, because obviously there's a rib in the way. If we tried to come in perpendicular here, it wouldn't work. So here we are now positioning the radiofrequency ablation probe. Again, you can see my hand is well away from the beam. The position of the actual beam is marked by the laser, but the probe is oblique, so it's oblique in 2 planes. It's oblique in the XY, and it's angling up from below on the Z-axis. So this is the real-time view that I get while we're actually capturing the nodule. So you can see the nodule that we're aiming to treat, and soon coming into the top of the image there, you're going to see the needle tip. That's the needle tip, a little bit of metallic artifact. So this is a real-time view, and you can see we've still got respiratory motion. Patient's being ventilated at this time. Just moving the tines out now, just starting to deploy the tines. That stabilises the needle slightly. Deploy the tines through the needle, bit of a push to splay the tines, and then pull the lesion back away from those pulmonary arteries, and that's the final position there, very nicely demonstrating that we've got capture of that lump, the lesion we're targeting, right in the middle of those tines. This is after a little bit of cooking. You can see that the lesion is much less conspicuous as we're starting to see some rarefaction of lung around the lesion. As the heating process commences, we get a dead zone, and this is much later. This is starting to reveal what I call a light bulb sign, where there's an envelope of consolidation around the outside of the part of lung that we've cooked. And the centre there of that envelope, as we just drift back down again through that area, you'll see the tines deployed. We've removed the needle, I think, at this point, so the tines are out, the needle is out, and we're just left with that dead zone, and the lesion itself has pretty much disappeared because it's been dried out, so it's just in the middle of an area of dried out, cooked lung. That area is necrotic, and that area will go on to produce an area of cavitation, dense consolidation and then cavitation. Okay, we're now chasing the next lesion. This is the lesion adjacent to the oblique fissure. You saw a little flash there of the needle up in the top right hand corner. We've started to develop a pneumothorax already. As I'm now real time moving the needle down, got to get underneath those ribs. This is a bit later on, treating the third final lesion. Now you can see an area of rarefaction around the needle. You can see the tines deployed through the mass, and we've got a fairly big pneumothorax at that point. This third lesion was the one which we always thought was going to produce a pneumothorax. So we had to place an intercostal drain in this case, and you can see there the tines deployed and the rim of consolidation. This is the needle after treatment. That's cooked lung adherent to the tip of the needle there, just showing how those tines get folded back in when you go to pull the needle back out. And finishing up the case there, just me taping in an intercostal drain, which we placed at the same time. So this is post-procedure now. There's a couple of spots there where the radiofrequency ablation probes went in. These are just little 3mm nicks. So we just clean up the skin, apply a couple of dressings, and the case is over. So we've treated the pneumothorax we produced. No pneumothorax on the right, but we did get a pneumothorax on the left. Got an intercostal drain in situ, and that's the end of the case.